Today, we're diving straight into a clinical masterclass on birth brachial plexus palsy. We're going to take what is honestly a pretty dense, complicated neurological pathology and translate it into clear, actionable understanding. We've got some beautifully structured visuals coming up to help map out the anatomy and the injury itself, so let's just jump right in. First off, why does this matter so much? Well, to grasp the clinical weight of this condition, we really have to look at its prevalence. This isn't some incredibly rare anomaly you're only going to read about in a dusty textbook. This injury actually affects up to 2 in every 1,000 newborns, so if you're working in pediatric medicine, obstetrics, or rehab, this is absolutely a critical scenario you need to be prepared for.
Here's the quick syllabus for our masterclass. We'll cover understanding the Palsy palsy, classifying the injury, clinical evaluation, conservative therapy, surgical interventions, and wrap up with some vital complications and clinical pearls.
Right, let's start with part 1, understanding the anatomy and the initial insult.
I want you to visualize this incredibly vital, complex network of nerve cables branching out from the neck, running under the collarbone, and extending all the way down the arm. So, how does this beautiful structure get compromised during birth? Well, it's all about the physics of the injury. The main culprit here is lateral stretch. This typically happens during a high-stress scenario called shoulder dystocia, where the baby's anterior shoulder gets trapped behind the maternal pubic bone. As traction is applied, the head gets pushed away from the shoulder. You can imagine the immense tearing tension that puts on those delicate nerve cables. And naturally, that risk goes up with higher birth weight infants and multiparous mothers.
So once that mechanical insult has happened, we move to part 2, classifying the pathology and severity. What exactly is happening anatomically when these nerves are stretched or torn? Well, the most frequent pattern we see in the clinic, about 75% of cases actually, is Erb's palsy. Because the upper cervical roots are the most exposed to that lateral traction we just talked about, the C5 and C6 nerves really bear the brunt of the damage. This essentially short-circuits the muscles governing the shoulder and elbow. Because of that, you'll often see the baby's arm internally rotated and just hanging straight down by their side.
Now, conversely, and this is much rarer in birth injuries, a Klumpke's palsy damages the lower C8 and T1 cables. This is pretty devastating for hand function, leading to a claw-like presentation. And here's a fascinating clinical connection for you. If that downward traction also pulls on the nearby sympathetic ganglion, you might actually see a drooping eyelid and a constricted pupil on that exact same side. That's a classic presentation known as Horner syndrome.
But we can't just look at the location. We have to gauge the actual severity of the nerve damage. For this, we rely on the Seddon classification. Think of neuropraxia like a violently stretched rubber band. The internal fibers are still intact, so it eventually snaps back to normal function. Axonantemus, on the other hand, is messier. The internal wire is broken, but the outer sheath remains, meaning recovery is a massive question mark. And finally, neurorehabilitation. This is a completely severed wire. It's either ruptured or violently avulsed straight out of the spinal cord. Without surgical splicing, that pathway is dead.
Knowing those classifications brings us nicely to part 3, clinical evaluation and the electrodiagnostic workup. When you step into the clinic, how do you systematically evaluate the true extent of this totally invisible nerve damage in a tiny newborn? Well, before you even touch any sophisticated equipment, just observe the infant's natural movements. If you test the Moro reflex, the startle reflex, and only one arm flings up, you instantly know there's a disconnect. You might also notice their neck tilted away from the limp arm, which is a condition called torticollis. The affected limb might even feel noticeably cool to the touch and look a little blue due to altered vasomotor control. It paints a really vivid, albeit tough, diagnostic picture.
Then, when we look beneath the surface with an EMG, we can literally see the chaos. When a nerve is severed from its muscle, those muscle fibers become highly unstable. What we're looking at here is the chaotic electrical static of damaged, crying muscles. Those fibrillation potentials and positive sharp waves you're seeing confirm acute denervation and axonal loss. But here is an absolutely critical pearl. Timing is everything with this stuff. If you do an EMG on day 2, it might look deceptively normal. You literally have to wait 3 to 4 weeks for those denervation signals to fully develop. Furthermore, sensory nerve action potentials, or SNAPs, are your absolute best friend here. If a baby has a completely numb arm, but their SNAP reading is perfectly normal, it tells you the sensory nerve is technically alive but disconnected from the brain. It means the nerve root was violently ripped completely out of the spinal cord. We call that a preganglionic avulsion, and sadly, it's the most severe injury possible.
Once we've evaluated the extent of the damage, we hit part 4, conservative therapy, splinting, and the timelines for recovery.
Management relies entirely on incredibly strict temporal milestones to maximize the child's functional recovery. Interestingly, we intentionally delay range of motion therapy for the first 2 weeks. Why? Because those damaged nerves are highly inflamed and literally painful when moved. Once that acute phase subsides, therapy begins. But the ultimate clock is counting down to the 3 to 6 month mark. During this window, we are watching like hawks for the return of elbow flexion against gravity. If a baby can bend their elbow by 3 months, they usually achieve normal function. But if they can't do it by 6 months, we have to pivot to a totally different path.
So what exactly are we doing during those critical waiting months? Well, therapy is a relentless daily commitment. One of my absolute favorite techniques is attaching little wrist rattles to the affected arm. You see, if a baby can't move their arm, their developing brain simply forgets it exists, a frustrating phenomenon called learned disuse. The rattle forces the baby's visual and auditory systems to acknowledge that paralyzed arm. We combine this kind of neurotrickery with careful splinting to prevent joints from locking up, and electrical stimulation to keep the muscle tissue viable while we cross our fingers and wait for those nerves to slowly grow back.
What happens when conservative therapy simply isn't enough? That brings us to part 5, surgical interventions and restoring the circuit.
What do we do when an infant fails to regain that crucial anti-gravity elbow flexion by 6 months? At this crossroad, we have 2 distinct pathways. The fantastic news is that 50 to 95% of infants recover beautifully through structured conservative therapy and the miraculous natural ability of nerves to regenerate. But for the severe cases, those sudden neurotomesis injuries, where the biological wire is fully snapped, we absolutely have to step in surgically to physically rebuild the circuit.
This is where some truly incredible surgical masterclasses happen. If there's a block of scar tissue preventing growth, we perform neurolosses to free the nerve. But if there's an actual physical gap, we do nerve transfers. We actually borrow intact, healthy electrical wiring from less critical areas like the intercostal nerves in the ribs, or even borrowing from the healthy opposite arm in a contralateral C7 transfer, and we plug them directly into the deadened muscles of the affected limb. It is quite literally biological electrical engineering. We can even use the sural nerve from the patient's leg as a biological extension cord to bridge large gaps. It's just amazing.
As we round out today's explainer, let's look at part 6, complications and clinical pearls. Before we wrap up, we really need to highlight the long-term pitfalls to watch out for, because even with optimal care, complications can and do arise. For instance, the lack of balanced muscle pull means the shoulder joint doesn't form correctly. This leads to glenoid dysplasia, where the shoulder can slowly dislocate posteriorly over time. The affected arm often ends up slightly shorter too. But here's perhaps the most bizarre complication. Around 1 to 2 years of age, some toddlers will actually bite and self-mutilate their recovering arm. We believe this is just their reaction to the intense, strange tingling sensation, the pins and needles, of nerves finally regenerating into the skin.
Okay, let's consolidate your absolute highest yield masterclass pearls. Number 1, unlike violent adult nerve injuries, say from a bad motorcycle crash, birth palsies are notably painless after the first 2 weeks of initial inflammation. So if a child with a birth palsy is crying in pain months later, you need to look for another cause. Number 2, never ever underestimate the diagnostic power of the sensory nerve action potential to identify root avulsions. And lastly, remember that the battle is largely won or lost by caregivers actively tricking the brain to prevent that dreaded learned disuse.
Which brings us to the end of our explainer, and a final thought to ponder. As we look at the incredible strides in microsurgical techniques, routing nerves from all across the body just to restore a baby's simple smile or grasp, we have to ask ourselves, how close are we to a future where we can flawlessly rebuild these delicate neural pathways, leaving absolutely no trace of the initial injury? The science is moving incredibly fast, and the next decade of neuroregeneration is going to be absolutely thrilling to watch. Thanks for joining me in this masterclass, and keep exploring.